Thanks everybody for joining. Thank you for having me. So I treat myeloma at Guy's and St Thomas's. What I thought would be helpful. Oh, I'm just going to minimize this. Hang on. Am I still there? Can you still hear me?
Yes.
Oh, good, fine.
Yeah. Yeah.
Sorry.
We can see you in the when it comes up in the chat, we can see you there as
Oh,
well.
you can see me.
Yeah.
Oh, good. Oh, fair enough. So what I thought would be a good way to begin would be actually just describing where it is that I work, because obviously it's quite different to in Zambia, and actually it's very different as myeloma treatment, even to other parts of England, never mind Europe and America as well. So myeloma is something um, which is a very rapidly changing area. And so how we treat it and the systems that we built around looking after patients to make sure they're treated safely has had to change over time a lot as well. So in where I work, so we have a big hematology department, and all hematologists are divided up into different sub teams. So I'm part of the myeloma team. Now there's a picture of us down in the corner there as well. So there's actually five of us myeloma consultants, two specialist nurses, who are really good continuing support for patients, and a prescribing pharmacist, and we look after everybody who comes to us with myeloma or other plasma cell disorders altogether. But then it's not just us as well. We're fortunate that actually for our patients, we can also give access to physiotherapists, dietitians, psychology support as needed as well. And the treatments that we give, there's lots of treatments for myeloma now, but it's very much protocolized. So myeloma, it's a long-term condition. The overall survival has improved really dramatically over the past 10, 15 years as newer treatments have come into use. But what we can prescribe is dictated by NICE, which is the body that approves drugs and drug regimens. And there's a particular pot of money that's given specifically for expensive cancer drugs. Um, Also, in terms of new developments, it's often a really beneficial thing to try and include people in clinical trials of new treatments as well, because it gives earlier access to new treatments, and also often more enhanced monitoring as well than what's typically available just on the NHS. Pardon, sorry. There we go. And then also we're part of a UK-wide sort of myeloma network of treating clinicians, and a UK charity as well called Myeloma UK that provides sort of information for patients as well. That's very standardized, which is really helpful. So, a lot of this is very much UK centric in terms of what we have access to in terms of being able to diagnose and treat myeloma. But like I say, it's very different even to parts of Europe as well, where they can access things that we can't, and things are very much changing a lot over time. Um, whenever Oh, I'm going to go back a bit. Sorry. One last thing to say as well is that because myeloma diagnosis itself has also moved on, actually confirming the diagnosis is taken through what's called a multidisciplinary team. So where we're linking with hematologists at local hospitals, and join in sort of weekly meetings with our radiologists and a dedicated hematopathologist as well to present patient investigations. And every patient that's newly diagnosed with myeloma will have the diagnosis confirmed through the MDT meeting, and it's documented and audited as well. And that is, again, it's to standardize an approach, making sure you're getting the right diagnosis, because without that you can't give the right treatment. And then also actually to fast track occasionally treatment as well when you have urgent findings as well. You can discuss radiotherapy, etc. So it's a really important setup to be able to give safe treatment. What is myeloma? So it's a cancer of the plasma cells in the bone marrow, and it's the far end of the spectrum of clonal plasma cell disorders. So plasma cells are what's essential throughout life for producing antibodies to fight infections, what can happen is that they can start to develop small genetic changes over time, leading to a clone of cells that are unregulated. This is the MGUS stage. By definition, has less than 10% clonal plasma cells in the bone marrow. But if this progresses, and it doesn't progress in everybody, then it can become myeloma, which is characterized by certain end organ features. So it's a clinical pathological diagnosis. That means, sorry, I've got a bit of a cold, so I'm sniffing. That means that it's based on the disease pathology. So a pathological diagnosis having clonal plasma cells in the bone marrow, more than 10% in the bone marrow, but also up until recently-ish, end organ disease or damage. Now that changed to incorporate certain high-risk patients to allow us to give treatment earlier to prevent damage, which I'll come to later. But yeah, it's a long-term condition, and typically when we give treatment, even how I discuss it with patients is that it's to get really good and hopefully very deep disease control, and the deeper disease control that you can get, the longer duration of disease control that translates into. But I always discuss when I'm discussing somebody with a new diagnosis of myeloma, I discuss with them that at some point the myeloma will rise up again and will need to give a different line of treatment. So this is built, the treatment landscape is built around lines of treatment, and with newer advances to try and extend life expectancy overall, which it really has done. And actually, as treatments have improved and as overall survival has improved, I think generally in the myeloma community, this has led to a shift towards more thinking about focusing on minimizing the long-term complications of treatment or managing late side effects, things like steroid toxicity or infection risk, and maintaining people's quality of life as they live longer with myeloma. And also thinking about how to give treatments and identify patients who actually might sustain really long treatment-free periods of disease control. So thinking about, and internationally, thinking about the concept of functional cure in myeloma for some patients, but also thinking about which patients can we identify who are actually higher risk of having aggressive myeloma that we really need to double down on giving more intensive treatments to try and improve their outcomes. And this is, oops. Oh, give me one sec, sorry. Oh, apologies. I froze. And this is a study which describes this sort of sequence of multiple lines of treatment. So this was a study which was led by a professor in London who did an observational study of lots of different hospitals around Europe, studying the outcomes of myeloma patients, of almost 5,000 myeloma patients who were included. And typically what you would see, so if the first line treatment is at the top here, I don't know if you can see my arrow, and then people relapse, and then they go into the second line of treatment, and then relapse in the third line of treatment. This was at a time when most regimens were fixed duration, but what you saw was that as people progressed through successive lines of treatment, that treatment-free interval or the progression-free survival would get shorter. And that's because of the effects on the immune system, on patient fitness, but also as myeloma relapses more through treatment, it becomes more genomically complex and harder to treat. So doubling down on the actual diagnosis, the official diagnosis of myeloma, this is the criteria. So the diagnostic criteria that's given by the International Myeloma Working Group, the IMWG. Initially, we went by the CRAB criteria. So patients would present, or what would be myeloma defining would be any one of these four features in the left box here, having myeloma driven hypercalcemia or renal impairment, anemia, or bone lesions, for which there's quite a strict definition. So there needs to be osteolysis on imaging. So we have erosion of the bone cortex. What then was updated in 2014 was a recognition that actually there were certain patients who didn't have these features, the bone damage, the severe anemia or renal failure, etc., but who were at particularly high risk of progressing to symptomatic myeloma within a 2-year period. So more than an 80% likelihood of progressing to symptomatic myeloma within a 2-year period. And that's these patients where on their bone marrow biopsy, they have more than 60% clonal plasma cells, or on the serum-free light chain ratio, so kappa to lambda ratio on their blood test, if the ratio is more than 100, so long as the involved light chain, either kappa or lambda, is also more than 100, or if there was more than one focal lesion on MRI imaging. When these were based on small retrospective studies, and actually the subgroups again were also small, so the evidence is limited, but nevertheless it was strong enough for them to say that actually if people have these criteria, even if they don't have anemia and renal impairment, then actually the risk of them getting end organ problems is so high that actually they should just be treated anyway. There is variation within these groups, though. So if I see somebody whose serum-free light chain ratio is over 100, and that's the only thing that they've got, then I'd still think carefully about whether I really need to treat right now or not, or whether I can monitor them very, very closely, knowing that where I work, actually, I've got access to good whole body imaging that I can do repeatedly, etc. And what's important, though, as well with this is about thinking about what test you're using to decide whether it is symptomatic myeloma or not. So, yes, looking at your bone marrow disease burden, and I put on the right-hand side here. So, if you have less than 10% clonal plasma cells in your bone marrow and your paraprotein is less than 30 grams per liter, then it's MGUS. If your paraprotein is either more than 30 grams per liter, or you have between 10 and 60% clonal plasma cells in your bone marrow, then it's smoldering myeloma if there's no other end organ damage, or it's plasma cell myeloma, symptomatic myeloma, if you do have end organ damage with more than 10% clonal plasma cells. What's important to note is that just plain X-ray imaging actually will miss a lot of patients who've got significant bone disease. It's not deemed sensitive enough. And so that's why, where possible, the IMWG does recommend more advanced imaging techniques, if possible. And that can be PET CT, whole body PET CT, or whole body low dose CT, or whole body MRI, or MRI spine with CT of the limbs. But it depends on what's available. And even in the different parts of the UK, actually, there'll be different imaging modalities which are available. It's not all universally available. Oh, sorry, my screen keeps. Okay, sorry, there you go. And then just as a caveat, like what I mentioned with the serum-free light chain ratio, when they added the serum-free light chain ratio being greater than 100 as being one of the diagnostic criteria, so in SLIM CRAB for symptomatic myeloma, it was actually based on really small subgroup studies. So actually within that, there's actually variation in people's risks of progression. So one way to unpick it can be about quantifying the degree of proteinuria, but also otherwise, it's very much MDT discussing and with the patient about whether to start treatment at that time point or not. Certainly, it can be a higher risk factor for progressing, but not always seen to the same extent with everybody. And just to say, it's also um, uh, formally put in the WHO Heme 5 classification of uh, uh, malignant hematology diseases, the definition that's given of your bone marrow plasma cell burden um, contributing to the diagnosis of myeloma versus MGUS. So, how do people present? What sort of symptoms does it cause? So, typically, people talk about fatigue, bone pains, the effects on the immune system that the myeloma causes, so recurrent infections, or feeling generally unwell, nausea related to their renal impairment, etc. Um, but actually, a lot of this can be really non-specific. So what I put here, this was actually it was a clinical trial that was done that was based in the UK, 93 hospitals in the UK. But as part of the trial, they actually surveyed patients to describe what symptoms they reported when they first were diagnosed with myeloma. So it uses the patient's own language, and um, actually, bone pain wasn't really a term that's used. They would simply report pain or back pain or fatigue, or just general systemic symptoms. So actually quite vague and non-specific, which is something which can lead to delays in diagnosis. And as you get delays with diagnosis, that's when people accumulate more complications before they're diagnosed and start treatment, and often their outcomes are worse. So with this in mind, certainly thinking about how things are where I practice, it's mean that there's been a real push for simple blood test screening in with people's GPs. So for doing myeloma screening blood tests, quick reporting of results, and actually flagging to us hematologists when there's a new abnormal result, a new paraprotein finding. And a lot around GP education for doing myeloma screening and access to hematologists for getting advice and guidance about results, but also about pathways for rapid referral as well. So, actually, if a GP does have a patient who comes to them saying that they're generally unwell, they've got some back pain, etc., then they do the myeloma test, blood test, then there's specific criteria where here they can actually refer into the hospital very quickly, and it's expected that we should see the patient within 2 weeks of the referral. And again, it's audited, it's a measured outcome that we're held to as hematologists. So it's designed to fast track cancer diagnosis and referral. Um, and that's the same actually for other types of cancers as well in the UK. And I put this in because I think it's important to think about, not just what tests would you be doing, if you have somebody that you think has myeloma, but thinking about the wider setting and the system as well, that you're working in, recognizing that actually things can be quite non-specific, how people present. So in terms of the basic first test you want to do, can you see that? The common basic blood test is, of course, your full blood count, your renal function, your bone profile, is to see is somebody anemic, have they got renal impairment, do they have hypercalcemia? But I also check things like their vitamin D level, particularly because actually one of the treatments, if they have myeloma, supported treatment, which I'll mention later, is about giving bisphosphonates, bone strengthening treatments, and then you can become hypocalcemic if you don't correct their vitamin D deficiency. I'd always check a virology screen, so checking HIV test. Sometimes you can have a paraprotein simply arise because of somebody's untreated or uncontrolled HIV, and then you treat the HIV and the paraprotein disappears. We've seen that a couple of times. But also check the hepatitis B status and hepatitis C status, particularly because that's an important safety thing if you need to start chemotherapy on somebody. In terms of staging, basic blood tests, I check the beta 2 microglobulin and albumin, and I've got a slide later where this goes into the staging that's given if somebody does have a new myeloma diagnosis. And then what's really important is your immunology studies. So if you consider, so your myeloma cells, they originate from plasma cells which normally make antibodies. What you would check is a serum protein electrophoresis, which looks at the spread of antibodies in someone's serum, to see if there's a particular band of antibodies all of the same type, which is the paraprotein. And then, because not everybody with myeloma has a paraprotein, they have more light chain disease. It's really important to check their serum-free light chains as well, the kappa and lambda light chains and the ratio. It can be helpful to check for proteinuria and also BNP for amyloid screening as well. Then, in terms of the next lot of tests would be invasive bone marrow biopsy. And so there's a few things that's done. Firstly, on your bone marrow aspirate, we will stain it. We use a MGG stain quickly to provide a quick estimation of the plasma cell burden. Often, bone marrow aspirates can underestimate your plasma cell burden, but it can still, if you see more than 10%, then it's likely you're dealing with myeloma, and then you just need to decide whether it's smoldering or symptomatic. And so it's a quick way of getting a diagnosis. What I've got here pictures where you've got typical plasma cells. So you can see this nice round. I don't know if you can see my arrow or not, but certainly you can see on the right side, isn't it, that there's these cells where there's this round eccentric nucleus to one side, like a fried egg, and then this kind of more blue cytoplasm. And then on the right image, bottom left, you can see there's a binuclear plasma cell. And then what I've put on the left side is something called a MOT cell. So what this is, these little bubbles are vesicles filled with immunoglobulin. That's just taking up all the space in the cytoplasm of this cell. So it can be typical features. The aspirate morphology, quick to stain and to look at, and can provide a very quick diagnosis for that reason. It doesn't tell you about clonality. So if someone has a polyclonal increase in their plasma cells, then it's not going to help you to differentiate that. What we do as well is that we send some of the aspirate for flow cytometry, or immunophenotyping. These slides, this is courtesy of our lead scientist in our flow lab at Guy's. So thanks to him for this. So what this is, so your bone marrow, aspirate, the cells, they're labeled with fluorescent antibodies against specific surface markers, and then they're passed through a laser device and analyzed to classify the different cell populations. And so then you can use this, see what antigens those cells are expressing, and say, are they all the same type, and what cell type, and how mature or immature is it? So we do that, and that can also give a hint towards the clonality of plasma cells. And just to say, so with flow or immunophenotyping, it can be helpful just to compare how the plasma cells appear sort of across the spectrum. So, normal plasma cells will be CD19 positive, like with other B cells, 38, 138 positive, and CD56 negative. And this bottom row, what that means is that they'll be expressing some of them expressing kappa, some of them expressing lambda light chains. With myeloma, by contrast, they're usually CD19 negative and CD56 positive, which is an aberrancy that anchors the myeloma cells into the bone marrow. It's an adhesion molecule. And then with plasma cell leukemia, which is the third one, the malignant cells, they lose their CD56 positivity. so they're no longer anchored in the bone marrow microenvironment and they can circulate. And this slide, it's just from WHO Heme 5 book, and on the top you can see there's a population of clonal plasma cells in red, and then the non-malignant cells are in black. So you can see that these red cells, they're CD138 and CD38 positive, 56 positive, and 19 neg. And you can see the ones in black, they show either kappa or lambda expression, but the one in red is really lambda expressing. So these are lambda restricted malignant plasma cells. And then just to say as well that flow cytometry, it can be used for detecting very, very low levels of malignant plasma cells as well, which is what the bottom one is looking at. Then on the trephine biopsy, this takes longer to get back, maybe 10 days or a couple of weeks for us. This can give more accurate enumeration of the myeloma cells. So it can quantify the plasma cell burden, but also they use immunohistochemistry staining to say, again, are they clonal plasma cells? And again, if it's less than 10% plasma cells, then it's MGUS. If it's 10 to 60%, it's myeloma, at least smoldering, otherwise symptomatic myeloma. Or if it's more than 60%, it's myeloma defining. Then also be able to differentiate well between other types of B-cell malignancies, because other types of non-Hodgkin lymphomas, they can produce paraproteins as well, so you don't want to be caught out. But also importantly at GSTT, our pathologists, if they're doing a myeloma workup, they'll always stain for Congo red as well, so for amyloidosis screening as well, which is really important. If you don't think about it to exclude it, then it can be very easy to miss. And on the trephine, I'm not a pathologist, but so normal plasma cells, often they're given in small clusters around arterioles, but in myeloma, they can be in focal nodules or more diffuse, so a different pattern. And then, oops. Oh, there we go. And then the other thing that we send on all of our newly diagnosed myeloma patients is cytogenetic studies of FISH, which is also important for prognosis. So what this is it uses live cells from the aspirate. Actually, I've got a slide next, actually, which describes it more. But it's looking at particular common chromosomal changes that can happen and genetic changes that can happen with myeloma. And there are certain ones which are particularly seen, which tie in with the myeloma being more aggressive. So it's actually built into prognostic scoring systems. And this is what this is describing here. So often what you see in terms of the genomic evolution of myeloma cells is that you get certain changes that happen very early on. These are these primary events. And often even in patients with MGUS, you may see this either that they've got translocations of chromosome 14, which is the immunoglobulin heavy chain gene. So it's a gene promoter where it gets moved onto another chromosome, and then it drives transcription of another gene that promotes cell division and cell replication. Or you get others where there's hyperdiploidy, where there's odd numbered increase in certain chromosomes. These are very, very common to see early on, but as MGUS progresses towards myeloma, you see that there's more genetic changes that happen and it becomes much more genomically complex. As people's disease goes through lines of treatment and relapses, it becomes even more complex and then harder to treat as well. Okay. So this is just a little bit more about what they do in terms of fish testing. So it's a really involved process with very specialist scientists, and it uses sort of sequential testing. So it takes time to get a result, but it's built into sort of standard prognostic scoring with myeloma. Oops. And then in terms of looking for myeloma bone lesions and also looking for extramedullary disease, whole body imaging is really important. And at Guy's, we're fortunate to have access to both to whole body PET CT or whole body diffusion weighted MRI. So these look at not just for in a high resolution way looking for active bone lesions in myeloma, but also looked at the degree of activity, metabolic activity of these as well. So you can compare over time if you repeat someone's imaging. Plain x-rays are deemed not to be sensitive enough. Actually, they'll miss cases. Once you diagnose myeloma, you risk stratify. So for a long time, in myeloma, we used the ISS score, which is on the left of the screen. And it's simple, it's straightforward. It just uses those two markers, serum, beta-2 microglobulin, and albumin level, and it divides patients up, newly diagnosed, into one of three stages. It doesn't incorporate any genomic data. And then the IMWG 2015, they revised this to then, for the first time, include certain high-risk genetic lesions. That's the RISS. So the chromosome 14 changes I mentioned, but also deletion 17p, which in pretty much I think all hematological malignancies, if you see it, it's bad news. And so, but there are still limitations to this as well, because actually, deletion 17p, it carries an even worse risk than your chromosome 14 changes in myeloma, but it's weighted the same way. So they revised this further into a more recent prognostic scoring system, which is the R2ISS. And what's helpful with this is that also then added a further cytogenetic risk feature, which is 1q gain, but also it takes into account that people can get progressive cytogenetic changes, which has an additive risk. So it helps to then divide these out. So the scoring system, if people have more than one of these genetic changes, it adds to their risk level. So helps to refine that further. And then even more recently, in fact, just last year, the IMWG presented this, which was an updated consensus risk scoring for patients with newly diagnosed myeloma, which for the first time also included TP53 mutation as well. Now, this has led to a lot of work in a lot of UK labs to actually update their laboratory pathways for how they prognosticate myeloma patients. It's not all fully aligned yet, but I think it does say about the pace of change in myeloma, both in terms of the diagnostic side, but then potentially in future how that might influence how we can adapt treatments for patients as well. Just as a side note as well, to say in terms of other high-risk myeloma features, I put these here as well. So it's not just about the genetics and about the disease burden, but certainly if someone has extramedullary disease, so soft tissue plasmacytomas outside the marrow, then that's a real scourge in myeloma treatment. It's very, very difficult to treat, and these patients can have very, very poor prognosis or quick relapse or high refractory disease risk. If the imaging is suggestive but not fully consistent with it being extramedullary myeloma, then often we need to get targeted biopsies of such soft tissue lesions to confirm that they're plasmacytomas. And that can help to then think about how you need to intensify people's treatments or add radiotherapy in addition to systemic chemotherapies as well. And then I just added here as well, so I can put it in somewhere, just about specifically about primary plasma cell leukemia as well. So this is by definition now of where you have more than 5% circulating plasma cells in your peripheral blood. It previously had been more than 20% circulating plasma cells, and then based on some review studies, this was revised down because it was seen in these that if people even just have 5% circulating plasma cells, the risk and the outcomes are the same as if they've got 20%. So very poor risk. People with plasma cell leukemia, it often presents with cytopenias, high calcium level, very high disease burden, can often correspond with also having extramedullary disease as well, and very poor prognosis and hard to treat. And even if they do initially respond, we've got a couple of patients at our end who are like this. You start to see a little bit of response, and then it quickly takes off again. It's very horrible. But that's a run through a diagnosis. What about treatment? So, like I said at the start, in the setting where I work, treatments are governed by NICE approval, which is the UK government committee approval of treatment regimens, and by specialist cancer drug funding, which again is audited nationally. It works through lines of treatment. So someone's first line, second line, third line, fourth line, which takes into account what treatments they've had previously, but also what treatments the myeloma has been refractory to before. But it's also not just about that, about the treatment exposure as well. It's also taking into account things like how fit the patient is, how old they are, what comorbidities they have, and also what their preferences are as well. We have quite a large catchment area across Southeast London, so not every patient wants to travel in to our cancer day treatment unit to receive treatments. They prefer to have tablets. It varies. And then we also always think about clinical trial access as well. The treatment regimens have exploded where it's such a fast moving area. So what I just put on here was about the key backbone drug classes which are used, and certainly the four in the middle are the big guns, which are really important backbone drugs. And what that means is often is that when you're thinking about access to other newer types of drugs, the criteria for which we're allowed to prescribe the newer ones means that patients have to have been exposed to these already, and often these are given in combination. But newer whole new treatment classes have emerged as well, and it's very very quickly changing. And what I can prescribe in the UK actually is different, even to Belgium, Germany, I think Ireland, very very different and changes quickly. Uh, 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 oh, there you go. So overall, the treatment pathway in myeloma in the UK, it's constantly evolving over time as new things become approved and funded. Frontline, the initial decision is whether somebody is fit for an autologous stem cell transplant or not fit for an autologous stem cell transplant. A stem cell transplant, it's an intensive treatment phase for consolidating someone's response to chemotherapy, where they need to be fit enough to be able to withstand actually being neutropenic potentially for 10 days or so, risks of mucositis, sepsis, neutropenic sepsis. So people typically will be under the age of 70 and be fit enough to undergo it. And then as we move down subsequent lines, I've got all these acronyms here, which are different drug combinations. But these are what I could see. Yeah, these are the things that we've got approved in the UK at present, but very quickly changing. So, I mean, the second line, the Bela PD, belantamab Pomdex, that was only approved, I think, 2 weeks ago. So it changes a lot. But with each line, it's based on what has the patient been exposed to previously. Because if the same thing that the myeloma has not responded to before, then it's not likely to respond again. And oops. And this slide I just put just to say about the frontline patients, how we would divide up whether somebody is transplant eligible, younger, fitter patients. Then we give a more intensive regimen, which is a 4-drug regimen up front: daratumumab, Velcade, thalidomide, dexamethasone, stem cell transplant, and then continuing maintenance. If they're not deemed transplant eligible, then actually now we can also give a 4-drug regimen up front as well, which also just continues. And this has been a move generally with newer protocols to actually incorporate a maintenance period to improve people's progression-free survival. Just touched on what an autologous stem cell transplant is. So what this is when somebody is going through their induction chemotherapy period, they also get referred to the transplant center. For us, it's at King's College Hospital, which is another hospital not too far from us. They undergo what's called a stem cell harvest, where they have certain treatments initially to mobilize their bone marrow stem cells, and then the stem cells are harvested through a machine, processed, stored, frozen. And then they have a planned admission where they're given high dose alkylating chemotherapy to essentially ablate their bone marrow, and then their own stem cells are returned to them. This is beneficial in terms of prolonging the duration of disease control, so long as someone's myeloma is already under control going into the transplant. If it's not under control, then it's not beneficial at all. And then post-transplant, actually what's, again, prolongs someone's progression-free survival is being able to give a maintenance period. And in the UK, the maintenance that we can give is lenalidomide. We don't have access to other types of maintenance treatment yet, but they are given elsewhere in the world. And then just to say with the subsequent lines, I didn't think it was very helpful to go into sort of specific drug mechanisms, but can do. But just to say that again, with lines of treatment, it's about trying to maximize the duration of disease control with each line of treatment, looking at what they've had previously, and trying to give something else which the myeloma has not been exposed to before, but also at the same time trying to minimize toxicities, infection risk, cumulative steroid toxicity, etc. And as the here I've put in so the big four in terms of the backbone drug classes: immunomodulatory drugs, which is your thalidomide, lenalidomide, pomalidomide; proteasome inhibitors, your bortezomib, carfilzomib; your anti-CD38 monoclonal antibodies like daratumumab; and then your alkylating agents we can give anywhere, but steroids. But they all have very similar common side effects in terms of myelosuppression, infection risk, but also certain very specific things as well. So peripheral neuropathy cumulatively can be a really disabling problem. A lot of people get side effects related to the steroids in terms of insomnia, fluid retention, weight gain, diabetes risk. But as we get newer drugs, we also get newer side effects to deal with. And it's been a big learning curve for us as clinicians, actually. So bispecific antibodies, I've got a slide on next, which are a much more recently approved class of drugs, which have a really powerful effect in controlling people's myeloma, even when it's multiply relapsed. But the way they work is that they can lead to, when you first start it, overdrive of the immune system, which can be life-threatening. So patients have to be admitted to hospital for monitoring to start these drugs. They can become severely hypogammaglobulinemic. So pretty much everybody on these drugs has to have IVIG. So that's intravenous immunoglobulin replacement that's given every month because it just depletes all of their B cells and they don't make any antibodies at all to anything. The belantamab can cause really severe corneal changes, so visual disturbance. So there's a lot of learning about how we actually can use these drugs, even though they're powerful, how we can use them safely. Um, Whoops. This I wanted to because it's been a really big one of the really sort of big game-changing areas in treatment. So I just wanted to include this. It's bispecific antibodies in myeloma. This is a class of drugs which we've been using. Oh gosh, I need to plug this in. We've been using for the past 2-3 years or so in the UK for people who've got multiply relapsed myeloma, where what happens is it's a antibody which has two bits attached to it, two arms. One arm binds to an antigen on the myeloma cells. The other arm binds to the patient's own T cells. So it brings their T cells in apposition with the myeloma cells, and their own bodies T cells will destroy their myeloma cells. Hugely powerful drugs, hugely powerful. But when you first start it, these are the ones where actually it can overstimulate their T cells, leading to a cytokine storm, and people need to be admitted to hospital to monitor for that, and have drugs like tocilizumab to dampen down their immune system. If they do get this, they can get neurological problems, and in the medium and long term, all sorts of severe infection risks. And we've seen people with actually really atypical infections who because of these drugs. Then, whoops. And then the last thing I wanted to touch on was, yes, having the I think having systems and having things you can audit and having updated policies and education and pathways for these patients is really important, alongside treatment improvements, but also so is the supportive care in myeloma patients. So, in terms of those patients with bone disease, it's recommended that they also, alongside chemo, have bisphosphonate treatments. Bisphosphonates, they switch off the osteoclasts in bone marrow, so they reduce the bone turnover. And that's been shown to help with reducing risk of pathological fractures, reducing bone pain, reducing the overall need for radiotherapy. But these can cause severe side effects as well. So one of the most frightening things it can do is cause death of the jawbone, osteonecrosis of the jaw, and that's what this picture is I put in here. Is got this exposed. So by the teeth, it's got this exposed dead bone is osteonecrosis. So our policy is that before anybody starts bisphosphonate treatment, even though they're important, they have to be seen by our dental team at the hospital to check it's okay. Because one of the risk factors is actually having poor dentition or poor gum health. Think about supportive care for someone's renal function, avoiding other nephrotoxic drugs like NSAID, unnecessary use of contrast with CTs. If people if people go into renal failure with myeloma and then they stay in renal failure, needing dialysis, that's a really poor prognostic factor. If you can get them to recover their renal function, it's really important in terms of their overall survival. Myeloma itself increases the risk of blood clots, but so do certain drugs, especially the IMiDs, the immunomodulatory drugs, thalidomide, lenalidomide. So all of our patients have thromboprophylaxis when they're on these classes of drugs, the IMiDs, and also cell mods, which are newer class of drugs coming through. And then infection prevention is really important, really encouraging vaccination, building into our chemo protocols about certain antimicrobial prophylaxis. We use acyclovir, which we dose adjust if somebody has renal impairment to protect against herpes simplex. But a lot of our protocols will also include other antibacterial drugs as well, or antifungal if there's lots of steroid use. And then IVIG, intravenous immunoglobulin replacement, is really important for hypogammaglobulinemic patients. These are really important things to keep people safe with these more and more intensive drugs. But yeah, that's my run through. I appreciate it's a lot, but I hope it's a bit helpful and interesting at least. Thank you.
Thank you, Neeraj. Does anyone have any questions? And also, just if people could fill in the feedback form, that would be really helpful. The link is in the chat. Uh, and if you have any interest in other diagnostic lectures, please feed back through Dr. Sahar, who will be able to let us know and we can see what we can arrange. Questions, if you put your hand up or just take yourself off mute.
Please ask. I realized it was like a total run through, wasn't it? Sorry.
I enjoyed it.
It was okay.
I'm educated.
Oh, good.
Good
I didn't want.
afternoon.
Oh, sorry.
Yeah, sorry. Hello,
Hello,
Dr.
yes, Dr.
Sahar, hello.
how are you?
She's asking how you are, Neeraj.
I'm very good, thank you. I have a little bit of a cold, so I've been sipping on Lemsip, but otherwise I'm very good. I hope this is helpful. I didn't think it's very helpful to go through like drug mechanisms and stuff because there's so much with that, and then all these trials and things. There's not, and I think what's really important is like I mean I when we have a new regimen come out, like I have to learn so much about how making sure that I'm dosing things correctly, preventing infection, doing virology screening. These are real bread and butter. So I think that's really important.
Yeah, this is what I wanted to ask, like for the follow-up of the patient. Um, Many of our patients come with a peripheral neuropathy side effect for medication. However, when we do like vitamin B12, we find that the vitamin B12 normal. Hello, are you getting me? Yeah.
Yep.
So, how do you manage the peripheral neuropathy in this situation due to side effects of multiple myeloma?
Oh, that's a really good question. And it's really hard, I think, because the peripheral neuropathy, if it's chemotherapy-induced peripheral neuropathy, I can be absolutely disabling. And sadly, I mean, I can think of a couple of patients where they get horrible burning pain in their feet. It's awful. Um, One of the things which I learned, so I'm going to plug in my laptop, sorry. One of the things which I've learned over time is from other lecturers is that actually you need to really closely monitor patients for peripheral neuropathy because actually the symptoms are delayed compared to the damage that's happening to their nerves. So when you get chemotherapy toxicity, it's to the long nerves going down to the fingers and toes. They're particularly most vulnerable. But when that damage is happening, actually, the symptoms related to peripheral neuropathy that happen are actually much delayed. So if you continue the same dosing, the same treatment, everything the same intensity, up until the point that they've got this, it's burning, it's keeping them up at night, they can't keep the bed covers on their feet because it's so painful, then actually it's too late. And so I think you're right to screen for things like their thyroid function and their B12 level. I pick up actually, I quite surprised. I do pick up patients who've got B12 deficiency separately, which is interesting. but then if I start to sense, as I'm going through treatment, I would think, okay, how high risk is their disease if I can get cytogenetics, or if they've got extramedullary disease, if they presented renal failure, how well are they responding? So how nicely is their paraprotein coming down? Have they hit a VGPR response? And then that gives me confidence to think, how can I adjust their chemo dosing? And that might be, and depending on the regimen. So, like so with Velcade, bortezomib, our standard dosing is 1.3 milligrams per meter squared. If I sense that someone's responding well, but they're getting to neuropathy, I might just nudge that down to 1 milligram per meter squared, because the effects, any ongoing effects, I'm going to see actually later. I won't be able to judge so quickly. And I really, and if it's very severe, I even have to, you have to think about even maybe reducing further, or small treatment pauses if needed. Then you get, in terms of symptom control, your neuropathic agents. So whether things like not fluoxetine, I forgot the name. Oh dear. Things like pregabalin, gabapentin, or other neuropathic agents, if they can help. Some patients, they find just that sensation of rubbing, things like cocoa butter and so on, just symptomatically can help a little bit as well. And it's so slowly titrating these things. I'm certainly mindful that if it gets very severe, then actually it can take much longer to get better. And then that you then think about, oh gosh, what are you going to do for your next line of treatment and the line of treatment after that, where there's also a neuropathy risk. So yeah, does that answer that? I think it's very hard. I think it's a horrible, horrible side effect. Horrible to have.
I think it's in our sitting here that take-home message I get, that we have to adjust the dose or decrease it, because we don't have a lot of facilities even to detect the risk factor or risk assessment. It is difficult in our sitting here. But I got the answer. I got the answer that we have not to keep going on and keeping the chemotherapy going on. We have to do something from the beginning, even adjust.
Yeah. Oh, you cut out. What does that have?
The dose or decrease the dose. Thank you.
I know. I think so. I think so. It's really hard, and I think it needs monitor. It needs, like, close assessment over time, to see how they're doing. And yes, if you need to adjust the dosing, then you have to. Otherwise, it can be really disabling. It's really tricky, I think.
Yeah.
Wonderful.
Thank you.
Oh, thank you. Thanks. Could I say as well? I just to say, next Tuesday I'll send the link to Yvonne and to Dr. Sahar. But we do, guys, we do these roughly every 4, 5, 6 weeks or so, like an integrated diagnostics seminar where different members of our lab teams come together and they present their aspects of a case. But next Tuesday, 12 p.m. UK time, we're doing a case. We're presenting the next case, and it's going to be one of our myeloma patients. We'll be presenting their workup. So it'd be nice to follow on from this. They'll probably explain it much better than me.
I
If you
will
like.
share the link with all the colleagues.
Yeah, please do. Please do. Be nice.
Thank you.
Cool. Any
Any other questions?
Was that helpful? Is it the kind of thing that you wanted, or I know it's
I think so, but Dr. Sahar, is that the kind of thing that you were wanting?
Yes, it is, but somehow it is like we don't have all of these facilities, but we hope one day we can like attend to our patients in this way. I like it, even the different drugs and the mechanism of action. I really like this slide. It's simple and straightforward. Thank Thank you.
Okay. Oh, that's good. I'll forward the slides. Anyhow, I'll forward that. It's really hard with myeloma because it's lots of really expensive drugs and also new diagnostics as well. I didn't talk about, like, MRD and mass spec, and we don't have access to that. It's all researchy stuff. But so I thought, like, yeah, at least just to share what it's like where I work, then yeah, because it's different. I think even if I speak to colleagues in Germany, their approach is different, to be honest. So yeah, but I'll share the slides.
Thank you.